Got to see if I can get this to go. Okay. Just like to acknowledge that the data I'm going to present today comes from two sources. One was the emergency laparotomy audit, which was carried out at 10 of 16 hospitals in WA, and also to thank the Health Department who facilitated us getting data from the Independent Pricing Authority to look at what's happening nationally, and in particular to Melinda Burmis, who did the hard work. She tells me there were almost 10 million pieces of data that she had to work her way through. Why the interest in emergency laparotomy? The data is really in two parts. Prior to 2012, there was a lot of historical data, mainly from administrative data sets, looking at outcome. And typically the mortality was around about 15%, which is obviously high, much higher in the elderly, but of particular concern, there was considerable variation in outcome. The most important variable they were looking at was average length of stay, which many would consider to be a good surrogate marker of quality of care. And this variation was associated with the variable and significant costs. From 2012, there's been quite a lot of contemporary data which has been prospective, but it does show that this variation persisted, and also evidence that comparison with evidence-based standards was poorly complied with, and that QI projects were changing practice. And this was really the first prospective data that was done. It was the Emergency Laparotomy Network, and just a couple of things I'd like to point out to you on here. Firstly, this is risk-adjusted, standardized mortality ratio by age and sex. Quite a wide variation here in these 35 UK hospitals. And I just draw to your attention one hospital here. Although this was an anonymous database, this hospital is outed itself, and it's the Western General Hospital in Edinburgh, where all colorectal emergencies, both elective and minor across the whole town, are managed by the upper and lower GI teams, with surgeons and patients moving around, and that may be relevant to what we discuss later. But it was this study that prompted the UK government to set up the National Emergency Laparotomy Audit. So if we're going to do the same in Australia, how many cases do we do a year? Well, it's very difficult to tell, but this is the basis of the information. We did a prospective audit in WA, where we're pretty sure we got all the data, and it was about 58 cases per 100,000 population, which fits in pretty well with the prospective data captured in NELA. We then looked at the IPH data, which provided us information on patients who were admitted as an emergency and underwent an emergency laparotomy. Obviously, it didn't include private patients because the IPA data only looks at public patients. And there were some patients who were admitted as an elective case who then had an emergency operation. And you can see down here what allowance we made for this. And this was based on reasonably good evidence from different places. And overall, we probably do somewhere between 1,350 and 1,550 emergency laparotomies a year across the country. But if you say this is fairly consistent data, and you make some allowance for the fact these are small states and territory, you have to ask, why does New South Wales do 41% more emergency laparotomies than WA? I don't intrinsically believe that they actually do that many more, and it's probably a reflection of the data quality, and this is administration. But the fact is, here's a highly expensive, highly morbid operation, and in Australia, we haven't a clue how many we're doing. In Perth, this is our data here, showing in the principal referral hospitals where most of the work was done, there was very little variation. There were a few deaths in hospitals that didn't contribute, but overall 5.4% mortality across the state. That's obviously slightly different from data from the UK, all prospective data. I think this 15% mortality rate is now historical, and most studies are looking at somewhere round about 10%. Scotland catches its data by flagging up emergency laparotomies, but I heard today that they're just about to set up SELA, which is the Scottish Emergency Laparotomy Audit. But hidden in this data is a very wide range of mortality when assessed by hospital, which we just don't see in WA. But if you go nationally, it's quite different. And this is the standardised mortality rate for Australia. corrected not only by age and sex, but also by DRG. A couple of things you should notice here. This variation persists, no different here than in the UK. Most of you will have heard of Mid-Staffs, a hospital that earned itself a commission of inquiry because over successive 3-month periods, the SMR of patients admitted as an emergency was 127%, and that earned them a special commission of inquiry. We have a lot of hospitals with a SMR greater than 127%. Now, to put that in context with what I've just shown you, this data was blinded to me, but it was given to me for the purposes of seeing how PILA data fitted into national data. And these 3 hospitals here are the 3 principal referral hospitals in the earlier slide. And you can see, even in this national data, very little variation between the Perth 3 teaching hospitals. That is not typical what's happening elsewhere in Australia. When we set up the study, we wanted to look just at not what we were doing, but also assessing ourselves against the bundle of care which had been used in the LKIP study, because that had been shown to improve outcome. And what they did in the LKIP study is they looked at their outcomes for patients who had emergency laparotomy, introduced this bundle of care, and you can see that they had fewer deaths in each of the 4 hospitals that had been used, and they reduced their mortality from 15% to 9.6%. Now, the Emergency Laparotomy Cooperative, which reported its results at a meeting about a month ago, was actually a scaled-up version of this to 28 hospitals across southeast England, and they've now reduced their mortality further to 8.7%. I could show you similar data, which I'll show tomorrow, that a similar study done in Copenhagen almost halved their mortality over 2 years. So the evidence that quality improvement changes outcome is very good. So if that's the situation, how do we do in Western Australia? Well, one of the things we looked at was the early warning score, and what I've used for the next few slides is the same green, amber, red used by NELA, and that if you've got more than 80% of the patients treated appropriately, then you've got a green. If you not so good, you've got a red. And this looks at the sepsis assessment and treatment with antibiotics across WA, and as you can see, a sea of red. We know that there is good evidence that if you give antibiotics within an hour in patients who are septic, they do better. A study out of New York showing that if you gave the antibiotics within 3 hours, that you reduce mortality for all causes by 14%. I think we have to say that we've failed. What about risk assessment and getting patients into theatre? And what we've looked at is the high-risk patients should be in theatre within 2 hours, should have a consultant, anaesthetist and surgeon present, and go to ICU, and if you like, the medium risks. And the message that comes out of here is that the clinicians did all right, that they achieved the standard and got a number of green points. The hospitals didn't. They didn't get the patients into theatre in time, and they didn't get them into ICU. This mirrors exactly what they found in NELA, and the last report of NELA was specifically made specific reference for this, saying that while the clinicians were getting their act together in improvement, there had been a failure by the hospitals to get their systems in place. But probably the single most important thing we found in NELA was the importance of risk assessment. And the idea was that every patient was risk assessed, and their future care was guided by the risk assessment. By chance, despite pushing hard, a third didn't get a preoperative risk assessment, but we were able to do it retrospectively. 2/3 did. You can see that if you did not have a risk assessment, your mortality rate was twice those than if you did. And perhaps it was because if you were high risk, you had almost half the chance of getting into ICU. You had a less chance of getting a consultant anaesthetist. But by then it was pretty obvious you were ill, so most of them ended up going to ICU. But these were high-risk patients, more than 10% risk of death. The expectation is they'd all go to ICU. They didn't. When you compare this against risk expected versus observed mortality, you can see that in every case where we knew of the risk, the observed was less than the expected, but if we didn't know the risk, the data is the other way around. And it is quite clear that you must do a risk assessment on these patients going to theatre. And once again, this mirrors exactly the data that we saw from the UK. Now, we couldn't really look at other aspects from the administrative data in terms of quality, but this is just an example of patients going to ICU. Patients who are greater than 80 who have an emergency laparotomy have a mortality rate of at least 25%, probably higher. You'd expect most of them to go to ICU. You can see here that each of these individual hospitals varied considerably in how often these very high-risk patients went to ICU, and it was less than 50% overall. And you would think that if you were having an emergency laparotomy, you'd want to go to one of these hospitals where you had a higher chance of going to ICU, and on the face of it, a lesser mortality. You wouldn't want to be up here. These three hospitals here are the WA hospitals, and in the emergency, the WAASM data, which is about to go out, about 7% of the patients who died, who didn't go to ICU, these assessor felt they should have gone to ICU. So you can get quite a lot of useful information out of this data. And this is also a very expensive exercise. So if you exclude the 10 cheapest hospitals and the 10 most expensive hospitals and look at this data using WAAS, so that's risk-adjusted cost basis, this is how the national efficient price is determined. You can see the cost of a laparotomy by different hospitals ranges from 20,000 to 40,000, so double the price. There's the national efficient price. These hospitals are inefficient. So where are we now? I would suggest we are where the UK was a few years ago, and we have prospective data that shows that we have poor compliance with evidence-based standards, and we have national data that shows that our outcomes and variations are really quite substantial, and that we really need to address it. And there is a good case for doing a prospective national data collection so we can all see how we're doing. But to do that, we need data. Thank you very much.